Thanks, Rob, and thanks, Janet, for having me. Excited to be here with all of you. It's definitely going to be fun doing it with 300 people. So a little bit about me. My name is Mike Cohen. I'm coming to you live from Albuquerque, New Mexico, and I am not a doctor. I currently work as a flight paramedic, a critical care flight paramedic on a helicopter out in New Mexico.
Cool.
I've spent time working on the East Coast as well in Washington, D.C. and Pittsburgh, and I recently spent the past 2 years working for the National Park Service in Yosemite, doing search and rescue and ground EMS as well. So what I enjoy about what I do is that we get a wide variety. So we obviously focus in emergency medicine, branch that out to critical care medicine, but we focus on adults, pediatrics, neonates. We do high-risk obstetrical transports. So whether we're going to a hospital to pick up a patient or we are landing on the side of the highway, it definitely gives us a lot of exposure. And so hopefully I can provide a different perspective. I think I saw some pre-hospital folks in the chat. Like Rob was talking about, we'll be using the ReelDx platform. It's a lot better if there's participation. So feel free to throw it in the chat. Rob and Janet, if you guys wouldn't mind helping me monitor that, like I said, there's one of me and about 300 of you.
We will.
And we're going to be going, awesome. We'll have a case presentation on a patient who has confusion and altered mental status. And we'll walk through them. I'm going to share my screen with you all. And hopefully you should be able to see that now. And like I said, we'll walk through that.
Yeah.
Awesome.
Put the CC on. Is the caption on?
Yep, closed captions on. So I have a speaker. You should be able to hear it. If you can't, you should be able to read the captions. And we have about a 2.5-minute video to give you kind of a window into what the providers are looking at.
Well, I'll obey my doctor. He says, no, don't screw around. Dr. Milner? Yeah. Dr. Milner? Yeah. Doctor, yeah. Right.
So what's going on today? Why'd you give them a call originally?
So ever since I had a TIA on November 6th last year, and ever since then I've been getting slowly worse at being able to maintain my coherence, I guess, on the road.
Okay.
It's slipping away, and I almost crashed my car 3 times on the way over here.
Okay.
I've found myself almost ditching it.
Just kind of losing consciousness, kind of?
Yes, actually I ran up on somebody's lawn today.
Okay. Any drugs or alcohol?
No.
No? Okay. Have you fallen down in the last week or anything? Hit your head? Nothing like that? Are you diabetic? Do you have blood sugar problems? Okay. How about right now? Are you in any pain right now?
I have a hernia, yeah. I'm in pain.
Okay.
I've been in pain.
But that's old stuff. That's nothing new?
Well, no, it's kind of new, but I mean, I had to walk 2 miles yesterday.
Okay.
It really hurts.
What hospital do you normally go to?
Meridian Park.
Okay. Standard questions. Any chest pain right now?
No.
Any difficulty breathing?
No.
Feeling nauseous or sick to your stomach?
No.
Dizzy at all?
No.
No. Okay.
Just
Very good.
I just can't stay awake.
Okay.
When I'm driving, and it scares the hell out of me.
What kind of medications are you taking?
Levothyroxine, aspirin, metoprolol, 50 in the morning, 25 at night. Omeprazole.
Okay.
Were you walking this morning?
D. Yeah.
I saw you walking down the side of the overpass this morning with a gas can.
Yeah, I ran out of gas last night at 11:30. And I went and woke up all the neighbors and pissed them off because it was a Lincoln Continental and I couldn't push it. I ran out of gas right out in front of Forrest's house. I didn't come back to his house, but I knocked on the neighbor's house on the front and they didn't answer. So I went to 3 other houses.
Dude on the way there.
And pissed everybody off. You know, but at least I got my Lincoln off the road. I was afraid
Rick would be fine. He's not complaining about any
road.
cardiac stuff.
It's too early to.
Alrighty. So, as is pretty typical, whether you're walking into an exam room or you're on an ambulance, don't totally know what's going on. So we'll start at the top of our assessment. And I'll make this point time and time again. It's important to know your standard patient assessment. Everyone develops theirs differently. So I'll walk you through how I do mine. Know your standard assessment, but over time you'll develop it to suit your practice. So what I like to do when I enter a room, the first thing I ask is this patient sick or not sick? Right off the bat, from the doorstep, does this patient look sick in need of immediate intervention or do I have some time? So I'll pose that question to you, sick or not sick? What do you think? And you can throw your answers up in the chat. Okay, I see a lot of 6. Anyone care to venture why? Why does this patient look sick to you? Okay, and I like people are saying you have some time. He looks out of it, laying down, depends on diagnostics, not moving much. Awesome. Awesome. So for me, the sick, not sick is there something I need to do immediately to save this person's life? That rolls into the ABCs. So ABCs, that's going to be your initial 15, 30-second assessment of the patient, again, in need of any immediate interventions. Airway is A. He has an airway. He's talking to us. B stands for breathing. Does he appear to be in any respiratory distress? What do you think? No, he's talking just fine. He's able to complete his sentences. No audible wheezing or anything. Awesome. And the C stands for circulation. So without, he has a blood pressure cuff on now, but without touching him, looking from afar, what do we want to look for to assess the circulation? Yeah, skin color is awesome, right? Does he look pale? Does he look pink? That's huge. Does he need O2? Okay, that's a good thought. Colors of fingers and feet, yep. That when you look at someone, if they're super pale and out of it, they're probably not perfusing. He's also mentating. He seems a little bit confused, but he's able to produce a sentence. He's talking to us clearly. He's getting enough blood to his brain. So circulation right now, I'm not super worried about. I also don't see massive bleeding, which goes into circulation. So he definitely could be sick. There's nothing we're going to do right now, so I'm not super worried. ABCs are intact. Again, nothing we're going to address right now. So what do we want to know? I see a lot of good things. What do we want to know with this patient? Okay, sugar level, awesome, and we'll get there. Blood pressure, so vitals, we're interested in vitals. What tools do we have available to us? We have pretty much everything. Past medical history, when did this begin? So breaking down what everyone's saying, I'm seeing we want to know his history. So we want to know a little more about this patient, why we're here, what his medical history looks like. And then everyone's talking about different vital signs as well. So we have the ability to get those vital signs. I'll present those in a second. These are all really, really important things. Let's start out with the workup. So I'm just going to start with history real quick because I think it's important to get a picture. And oftentimes when we walk in the room, one of the first things we're going to ask is what's going on? Why are we here? What do you need? What do you feel? So patient states, and you probably got this from the video, we'll recap. He almost fell asleep a few times, almost hit a tree, stopped by a Good Samaritan's house who helped him with car problems. It appears that there's someone in the video who called 911. Sounds like maybe the patient's family. They're not really sure what's going on, but the patient seems confused. When we ask him about his medical history, I'll come back to that, but it's extensive. Patient also states constipation so bad he used a Coke bottle to give himself an enema. Not how I'd go about that, but definitely a possibility, and we'll entertain that. Denies drugs and alcohol, and they states he hasn't been eating super well. So that's the history we have. Again, not super helpful. I'm still left trying to figure out why are we here? What does this patient need? What is he feeling? So hopefully that gives a little better of a picture, but again, pretty common to not have a full picture, have a ton of ideas what's going on. So we'll go into vitals and demographics. So as I said, he's a 64-year-old male. We find him lying on the couch. It appears that someone's called EMS, so someone's called 911. When we go to get vitals, so we'll put him on the monitor, heart rate of 84. What do you think about heart rate of 84, good or bad? Okay, yeah. 60 to 100 for an adult is our normal range. He's right in the middle, all good. I'm fine with the heart rate. What about respiratory rate? He's breathing 16 times a minute. Distress, doing okay? Yep, totally fine. 12 to 20 is our standard, but again, he doesn't appear to be in distress. Pulse oximetry, what about 99%? RA stands for room air, so he's not on any oxygen at this point. Okay, all good, yep. 94-ish to 100. Everyone has different levels, but 99 is perfect. And blood pressure, 178 to 98. Okay, so I see high, not great, a bit high. What if I were to tell you that he had a history of hypertension or high blood pressure? Makes sense, normal. Okay, yeah, definitely still high, but it makes sense, right? We would expect it to be high. It's not super out of the blue. What if I were to tell you that his blood pressure was 210 over 110? Whoa, yikes, bad high. Yeah, that's super high. Regardless of him having hypertension or high blood pressure, that would be something that we would be worried about. 178 over 98 could be okay. That's still pretty high, and that's still something that I'd be concerned with. So those are his vitals. Overall, nothing we're going to fix immediately, so I'm okay with that. And his only complaints, so signs and symptoms, his only complaints are that he's feeling lethargic, a little sluggish, right? He's weak, and he appears to be confused. When you ask more questions, you're told from the patient or the family member, as far as past medical history, PMH, he has kidney failure. He has a cardiac history. Not sure what that means, right? That can mean anything, and patients will tell you that. Could be helpful, could not be. He does have a pacemaker in place. He has a history of HTN or hypertension, so that explains the blood pressure a little bit. Anyone know what a TIA stands for?
Trans-ischemic attack.
Yep, transient ischemic attack. Perfect. So for those of you who don't know what that is a transient stroke or a mini stroke, a stroke that presents with neurological symptoms. So something ischemic, there's some sort of embolus blocking blood flow to your brain, and then that passes and it opens up. So for a short amount of time, you're having neurological symptoms, it goes away. Oftentimes that means that you're a lot more prone. And again, you have those risk factors to have a real stroke that is permanent, that doesn't just go away after 10, 15 minutes. So that's something that I'd be concerned about. And then he has a hernia. Does that mean anything to us right now? Is that super pertinent? Yeah, no, it's good to know. But it's nothing we're going to fix right now. He may be in a little pain. He tells us that he's allergic to multiple, including psych meds, Depakote, Valium, Risperdal. So that to me tells me that he has a psych history. He's been tried on all of those meds. He's familiar with them. And once we get to medications, I'll plug this. I think it's super important for everyone to learn their pharmacology and know it. That can paint the entire picture for you. Just by knowing what the medications do and what they mean can tell you the entire history. So he lives alone, social status, we don't really know what preceded these events. He tells us a lot, but we're not sure how pertinent that is or if we can really rely on that. As far as medications, he's on levothyroxine. Anyone know what that's used for?
Thyroid?
Yep. So someone who has hypothyroidism or low levels of thyroid. ASA stands for aspirin. So he has a cardiac history. A lot of people take a daily aspirin. That's pretty normal. What about metoprolol? Yep, good. Metoprolol is a beta blocker, so it can be used to control heart rate, can be used to control blood pressure, probably for him blood pressure. Looking at his blood pressure, it doesn't seem to be too controlled. Maybe he missed his meds. Maybe he's just not taking a high enough dose, right? But that helps paint a picture. And then hydrocodone. What is hydrocodone, or what's that used for? Yep, awesome. So it's a narcotic pain med. Totally. So all good to know. Now that we have a little bit more of a history, and now that we have some vitals, we've done a better assessment, we've asked more questions, we know his medical history, what do we think? And I don't know if OMAP results supposed to be listed. I don't see it. Any thoughts? What's going on with this gentleman? Okay, so I see dehydration, allergic reaction, stroke, drug-related confusion, diabetic, brain damage from the TIA, diabetes. seeing a lot of good answers. And at this case in point, or at this time, we don't know, right? I can give you a list of 15 differentials. What else do we want to look at? Someone said something before, another vital sign or another test we can do. Yep, blood sugar is great. Awesome. So we will get a blood sugar. So on our blood sugar, it's 83 for capillary blood glucose. 83 normal? Are we okay with that? Okay, yep, 83 is fine. For an adult, 70 to 120 is acceptable. Different ranges I personally, we treat under 70. 83 is great. And doesn't seem like he has a history of diabetes. So we can kind of rule that out. No hypoglycemia or hyperglycemia, although that'd be really high on my differential. And we'll talk about that in a sec. Under physical, and we'll get back to the physical, see GCS of 15, so Glasgow Coma Scale, which essentially means that he's opening his eyes spontaneously, gives good verbal responses, responds to all commands with motor function. So no worries there. We do an EKG because we can. What does NSR mean? Awesome, normal sinus rhythm, perfect. A normal sinus rhythm is just what it sounds like. It's normal, good conduction, nothing that we're too worried about. Let's see. I believe there's a picture. If anyone does, I wouldn't expect anyone to know how to read an EKG, but here's a picture of it. If you do a 12 lead, it looks fine. No signs of myocardial infarction or any aberrant rhythms just from looking at it. But again, I wouldn't expect anyone to know that. And then again, on a physical, so swollen feet, skin is pink, warm, and dry, PWD. We see some white around the corners of his mouth, superficial cuts on lower legs, and various stages of healing. What does that tell you? Okay, so yeah, definitely could be some pulmonary edema, or excuse me, pedal edema. Yeah, so water retention, swollen feet for sure, and we'll look at that. There's something really big, superficial cuts on legs and various stages of healing. And Brandon and Juliana, that's great. Slightly uncoordinated falls. I'm not as worried. I hear you on the self-harm. I'm not as worried about that. I would be more worried that he just can't take great care of himself. He's falling a lot. He struggles to get around. He keeps on having these cuts, right? That to me is pretty worrisome. And we see these signs in a lot of patients that struggle. He lives alone. If he's struggling from multi-mental status, that could tell us a lot, and it may not just be an acute issue right now. So that's a good sign to note. White around the corners of his mouth, could be dehydrated. So all good. And then clothes are torn, so he clearly isn't. Yeah, Janet, exactly. Struggling to live independently, struggling to stay healthy, poor self-care, and that can tell you a lot about a patient's state. Awesome. Does that give us any more insight? I'm going to touch on one more thing too. Patient, and again, this is under the history. It seems like the patient's very loquacious, so he talks a lot. Talks about things that aren't making sense. And it was hard for me to get all of this just from the 2-minute video. But when we dig more, patient feels like a bipolar manic or borderline personality. And some things that he's talking about aren't based in reality. So that to me seems like flight of thought, which is a term to describe mental state often found in bipolar manics, people with borderline personality. Yeah, possible dissociative states, perfect. Someone asks about pupils, and that's awesome. I don't have an answer for you. I'm going to go ahead and tell you that his pupils are equal and reactive around a light, 4 to 3 millimeters when you shine a pen light. So all good. No worries on the pupils. If they were pinpoint, what would that indicate? Okay, I see someone says overdose if we have pinpoint pupils. What type of drug? Now I'm just going in depth. But I feel like you guys probably know that. Opioid, perfect. Yeah, so pinpoint pupils, opioids, that's a telltale sign. Someone said head trauma. If he has pupils are unequal, so different sizes, that could be a sign of herniation and head trauma. Based on his presentation, I won't expect to find that, but that's definitely a good thing to put on our differential. So these are the tough patients, and this is why I like this case study. Again, the differential list is super long. There could be a lot of things. It's really hard to nail it down. We'll go into differentials in about 2 minutes, but as far as standard of care, what do we want to do for this patient? And again, I am familiar with the pre-hospital setting. Whether we're in the emergency department or in the pre-hospital setting, we're going to place the patient in the ambulance. If you have all the scope in the world, no limitations on what you can do. Any thoughts on things we want to do for this patient? Yeah, in the hospital or on the ambulance, wherever. I like, yes, Ty, you said see if you can stand. I like that. Does this patient ambulate on his own? Does he stand? It seems like he does. He's been walking around. We'll see right now. That's good. I really like that. You get a psych history for sure. Oftentimes, patients in acute psychiatric crises don't give the best history at that time, but that can tell you as much as you need. Get him more help at home. Contact family members. Yeah, it seems like a family member may be on scene. Everyone above was saying hydrate, fluids, start an IV. So all good things. He definitely seems dehydrated. It sounds like he's been walking around, moving around a ton. I would definitely be cautious in rehydrating him with large amounts of fluids due to his renal issues, due to what seems like some water retention, as well as his hypertension. That being said, he could probably use a small bolus, maybe give him some water. You know, everyone always talks about not giving water to patients. In reality, we typically don't do that if we're expecting a patient to go to surgery, but there's nothing wrong right here with giving him some water if he can tolerate it. So definitely rehydrating him. If we're in a hospital, getting labs for sure. That can also paint a different picture. So we'll move into differentials. Looking at this patient, and I'll go through this list. We'll scan through and we'll actually talk about it. It's super long and it spans the entire scale. So atypical MI, CVA stroke, sugar issues, so hypo or hyperglycemia, dehydration, hypertensive crisis, psychiatric emergency, substance abuse, including ETOH intoxication, and then malingering. So I'm going to switch screens for a second. Something that I use, and I think a lot of people have probably heard this acronym. It's called AEIOU TIPS. And it's an acronym to remember a lot of the different differentials for altered mental status. There are a lot of different versions of it, but again, it's all pretty much the same. So for A, we'll move into alcohol, acidosis, ammonia, arrhythmias, intoxication. Is this patient intoxicated? Do we smell alcohol in his breath? That paints a huge picture for us, and that could be pretty typical. That being said, there are a lot of patients who drink who also have a lot of medical conditions and underlying things going on. So that's something that's important to rule out and not just jump into and not dedicate. Yeah. I just found this on Google. Here's the link for it. Endocrine electrolytes encephalopathy. He definitely could be having an electrolyte imbalance, especially with his medical history. That would be something we diagnose more in the hospital with labs. That would be able to do a full panel on blood work. Infection. So is anyone familiar with sepsis? Anyone know what sepsis is? Awesome. Well, I believe the number one, maybe it's the number two leading cause in altered mental status in the geriatric population is sepsis. So sepsis essentially is a mass infection. It can start as something super small, but it leads to multi-organ dysfunction and often presents in the geriatric population with altered mental status. He's been falling a ton. He has cuts all over his legs. Is one of them infected? his vital signs right off the bat don't present with sepsis in mind. He's not hypotensive, so his blood pressure is not low. He's not tachycardic, so his heart rate's not fast. His respiratory rate's not fast. It'd be good to get a temperature, but sepsis is something to always consider, especially in that population. So oxygen overdose, opiates. He has a history of opiate use. Something I always like to do is discuss with my patients what their medications are, and then if we're at their house, I'll try to look at their medications. Is his bottle empty and it was just refilled yesterday? I can paint a picture. Again, looking at pupils, he's talking, he's breathing normally, he's has good oxygen saturation, so I'm not too worried about him being hypoxic with low oxygen saturations or opiates. Could he have overdosed on his other medications? Totally. So that's something that we would like to investigate more. Uremia, so infection in his urine, or like a UTI, urinary tract infection. And that's, again, a UTI is the most common source of infection in the geriatric population. So super important to look at. Trauma, temperature, thiamine. So someone mentioned head trauma. Did he fall on his head earlier? I on a patient like this, I would, when I'm doing my physical exam, I would get hands-on. He's confused. There's something going on. He may not be able to give you the full picture. It sounds like he doesn't take great care of himself and he may have fallen. So getting hands-on, feeling his head, feeling down his neck, seeing if he has any neck pain. He said no trauma. Do you trust him? I wouldn't. I sure wouldn't if I was dropping patient off. Nothing like saying that there was no trauma, and they do a more in-depth assessment and find it. So I would definitely double check. Temperature, is he hot, cold? Pain check. Yeah, we do the pain check for sure. For him, he says he has pain. I would ask him on a scale of 1 to 10, what's his pain? If he's able to give me a good answer as we assess and palpate different parts of his body, I'd check in with him to see if he has pain. Perfect. And then insulin, so our sugar issues. Hypoglycemia can manifest in altered mental status and confusion initially. It can manifest in patients being unconscious. That's probably one of the first things I check to rule out. There have been a lot of cases of patients who've been in custody for alcohol, but it turns out that their blood sugar was low and they've died. So I always check a sugar no matter what on these types of patients. Poisoning, again, did he overdose? Did he take too many of his medications? Psychiatric, so again, he's allergic to 3 different psych meds: risperidol, Depakote, and Valium. Valium's a medication for anxiety. Depakote is used mostly for seizures. It's an anti-epileptic, but also used for acute manic bipolar. And then risperidol can be used for schizophrenia, bipolar, anxiety. So he probably does have some sort of psychiatric history. Again, really important to rule out all medical conditions, everything else, before we just go with psychiatric, because people do have psychiatric conditions with underlying medical conditions. And then last but not least, stroke, seizure, syncope, shunt. So VP shunt malfunctions in the pediatric population is really important to be aware of and can cause altered mental status. For him, he has a history of a TIA. He has a history of high blood pressure. He definitely could be having another TIA. And he is definitely at risk for having a stroke. So that would be something I'd be worried about. When I think of differentials, I like to think of what's going to kill this patient first, what's the most severe, and then we can work our way down. Strokes are super time intensive. Time really matters. Time is tissue, time is brain. So I would be worried about that. He may have had a seizure and he's waking up from that seizure. He's in that postictal state, that state that happens after a seizure where there's oftentimes confusion. But without knowing his history, without it being witnessed, we can't say for sure. And then syncope, or another term for fainting. So that doesn't seem super likely. I would be concerned for a stroke.